Now, iron deficiency anemia in a minute. This is a very important topic because this accounts for about 50% of the anemia worldwide and it accounts for 1 million deaths annually. The etiology is simple. There will be either decreased intake due to a poor nutritional status or decreased absorption due to chronic diseases affecting intestine or malabsorption syndrome, or there is increased demand just like infancy, puberty, pregnancy or patients on erythropoietin therapy, or there is increased loss. Two types of losses are possible, either menstrual loss in women of childbearing age group or men and postmenopausal women can have gastrointestinal loss, especially GI malignancy. So always remember hookworm infestation in children, menorrhagia in females of childbearing age group and gastrointestinal loss in men and postmenopausal women. Clinical features, just like any other anemia, the symptoms will be similar. They can have easy fatigability, shortness of breath. On examination you will get pale conjunctiva, angular chelosis and spoon-shaped nails, otherwise called as koilonychia, as well as you can get a short systolic murmur in the pulmonary area. Investigation, the screening test is ferritin, but for exams always start with complete blood count, hemoglobin will be decreased, mean corpuscular volume or MCV will be decreased and your red cell distribution width will be increased. If you do a peripheral smear, you will be getting microcytic hypochromic anemia. The closest differential diagnosis are anemia of chronic disease and thalassemia. You proceed with iron studies, everything will come down like serum iron, ferritin or transferrin saturation. Only one thing goes up, that is total iron binding capacity. And you want to know the etiology of iron deficiency anemia, you proceed with upper and lower GI endoscopy, ultrasound of abdomen to look for causes of menorrhagia or GI malignancies. If needed, you can proceed with CECT or contrast CT of abdomen also. The treatment of iron deficiency anemia, you have got three options: oral iron therapy, parenteral iron therapy or red cell transfusion. The best option will be oral therapy. You have got multiple preparations like ferrous fumarate, ferrous ascorbate and ferrous gluconate. The major problem with oral iron therapy is gastrointestinal intolerance, where your patient will develop dyspepsia, bloating sensation, constipation, etc., where you may have to consider parenteral iron therapy. So the indications for parenteral iron therapy are patients who are not compliant to oral therapy, or when your patient is having a chronic gut disease where your iron absorption is impaired, or you need iron on a regular basis, something like a dialysis patient, where you can consider parenteral iron therapy. The initial preparations are iron dextran, all those things, but now we prefer iron ferric carboxymaltose like preparations where the chance of allergy is very less. Still always consider the possibility of anaphylaxis. And the next and the last option is red cell transfusion or RBC transfusion, which is usually done when your patient is having continued or ongoing blood loss, or when your patient is having cardiovascular instability in the form of angina or congestive cardiac failure. Here also the major problem is anaphylaxis. Okay, so these are the three treatment options. Okay, thank you.